2003. So here I am. I went and collected 4 degrees along the way. I'm currently working on my doctorate at Samuel Merritt University in Oakland, and I'm going to be a family nurse practitioner in the doctor of nursing practice. So I've worked on some publishing with Elsevier. I've done a few different drug calculation textbooks. I've contributed to, along with their SurePath online drug calculations platform. I've been teaching at a local community college since 2008 as well, teaching RNs and LVN students. And people have been asking me, so what are you going to do when you get your nurse practitioner? So as I'm doing my research and I'm looking out in the market, I say, what is a nurse practitioner going to do out in the world? I run across this huge wound problem that we have. And I find that we have a lot of gaps and a lot of ways that we can use modern technology that we can come in and make some changes. So that's what we're going to do. I started UberWoundCare. That's a Delaware corporation. And I created a mobile application. I'm going to talk a little bit about that today. It's more the process that we're going to talk about versus my specific company. We can talk more. I can show you the app and we're done. So as we know, chronic wounds, depending on the literature you read, there's probably about 8.5 million chronic wounds in the U.S. each year. As of this year, it's over a $30 billion a year problem. Okay, I call it a problem, not a profit center, because we do want to, make this smaller. I'd like to work myself out of business a little bit and get a grip on this issue. And then the wound care products business itself is about $8 billion per year and growing about 7% annually. For me, this is not a good thing. We could probably be doing other things like preventative health or prolonging life or different types of things we can do with our medical talents. Despite our best efforts with hyperbarics, different wound clinics, but getting our hands on our patients is often challenging unless we actually go to them. So how does this chronic wound problem happen? A lot of patients these days lack a primary care provider, as we know. Even with the Affordable Care Act and insurance, some people don't take it. Okay, so they also have a lack of access to a wound care center. They have some mobility issues. Some people may require transportation. They may be homebound. They may be having pain. They may not be able to get out of bed. They may need to have a loved one that has to take 4 hours off of work to drive them down to the wound clinic or the primary care physician to get them fixed up. Some of them may rather not go in. They may go in and get a debridement and it was painful, and they get home like, oh, I don't want to go back, and oh, it's not so bad today. So they put it off, they put it off, they put it off, and then I'm an ICU nurse by trade, so then they come and see me because they're septic. And we know septic kills people, right? So there they go. So those are some of the issues that keeps people away from our hands so that we can take care of them. So the gap we're going to fill is modern expectations of the patient going to the provider. Okay, we're going to get old school high tech. Okay, we're going to change the way we do home care with wounds. With over 3.44 million nurses in the United States today, that's in all 50 states, roughly 200,000 of them are certified in wound care. They're not all working in home care though. We have a lot of people in hospitals. We have over 810,000 licensed physicians in the United States. There's about 1,000 freestanding wound clinics, or about 20 per state, and about 800 different wound care programs in the different hospitals and facilities across the U.S. Still, that breaks down to about 18 patients per day per facility. Are you seeing 18 patients a day each? Maybe more, maybe less. We want to treat wounds in the community that we can treat. Okay, those ones that come out, whether they're chronic, whether they just came out of surgery, that first 60 days, as we were talking a few minutes ago, we want to make sure these things don't get infected. We want to get them healed as quickly as possible. We know that intact skin is the best barrier against infection, so we want to return to that as quickly as possible. So what are we going to do about it? Well, telemedicine video consults using dermatology to visualize the wounds is what we're planning to do. Use a 5 to 15 minute video consult. For ourselves, we use VC, which is a HIPAA compliant mobile application. What we're doing is putting this in the hands of the patient and the providers and the nurses. Okay? No special equipment needed. Whatever mobile device you have, hopefully your screen is not too small, but whatever mobile device you have, you're able to use that. So telehealth video communications between the nurses and the patients. I'll give you a rundown in the app of how this all works here in a minute. We'll be able to do follow-ups. So you can do a live video consultation. You can say, hey, you came out and you changed my dressing the other day. Can you take a look at this? And you can actually show that wound, the dressing. You can talk the patient back through on how to reapply it with the supplies they have at home. You may or may not need to go out there. We have a huge rural population as well, even those in metropolitan areas. I don't know about you, but getting to go anywhere to go see somebody takes time. And if it's only going to be a 2-minute conversation, why not just do it over video? Then you can determine if you need to go see them. So we're going to visualize the wound remotely before the next management episode, and we will refer or bring them into the office PRN. For us, we use tissue analytics. Has a standard size 3/4 inch Avery green dot. You take a picture, gives us a surface area. We get rid of the 50 to 55% error rate you get with a tape measure. It accurately measures the wound, tells you the tissue typing, and we have a nice PDF report we attach to the medical record, and we can send it to the discharge planner, the case manager, back to the primary care doc, and whoever needs that, whoever's authorized to see that. So nurses will be trained to do wound management versus dressing changes. Even in the nursing school, they're taught to do some standardized dressing changes. Not everybody's taught how to do negative pressure wound therapy. A lot of people are still taught, standard wet to dry, which is fine, using their Dakins or whatever. Excuse me. So we're going to train them how to do that for ourselves. We have a specific webinar that's live that works with Cheryl where they get to understand what our formulary is and the types of wounds that we treat. We want to treat the wounds that we absolutely can treat, those that are more infected, those look a little bit more angry than others. We need to refer those out as quickly as possible. Get them to the wound clinic, get them to a physician, get them to the ED. So if it's oozing pus and it's not so bad, it's like, no, you need to go to the hospital. We'll be able to do that because we'll have a doctor in the pocket. Contact one of our on-call docs. They can talk while the nurse is there and get that patient into the hospital if they need to be. So we can do assessment, biofilm removal when we're on site, do the digital photos, and collaborate with those other providers and get all that coordination done. So what are we going to do about it? We're going to crowdsource nurses locally on a short hour basis per visit, typically 30 minutes or less. And all the nurses I've talked to hundreds of nurses. Most of them that I work with in the ICU or even people I meet in med surg in different units do not want to work an extra 8 to 12 hours a shift in another facility, and they don't want to do it in home care. But they will work 2 to 4 hours a week on a per diem, per fee basis on their way home in their local area, around the corner in the neighborhood to go in and do a half-hour visit. Okay. They're going to make a little bit more money like they make in the hospital, for example, and they'll be able to get a grip on this problem. So for home care agencies that may only have 5 staff members and they really need 10, they can ramp up or ramp down as they need to. So the nurses get to decide what their availability is. I'm available Tuesday from 8 a.m. to 10 a.m. That's it. 10-mile radius, we're good. Okay. That kind of thought. We're using working RNs, LVNs, NPs, PAs, physical therapists that can do these E&M episodes. It's going to reduce the travel time. Again, the whole idea is to utilize people in the area versus people that are going to come out of the way. We don't want people bouncing around. Those of you in home care, it's like you go over to this patient's house and drive all the way across town, and then your 2 o'clock appointment's all the way across town. I've spent some time with that and some case managers in home health, and it bounces around a lot. There's a lot of time on the road. So we're going to readily access those rural areas. Metropolitan is a huge market as well, but the rural areas, we have about 17.5% of the population that live in the rural areas. As we're flying into Denver, we were looking down, looking at all the different ranches and how remote they are. But on top of that, 15.9% of the nurses in the United States live in those rural areas. Many of them commute out of the area to go to different hospitals and different facilities. Well, guess what? They have to go home from those places. So on their way home or on their way out, they can stop by and do these E&M episodes, should they choose to. So we'll be able to completely track and monitor wound healing. We're going to incentivize early and appropriate healing. So if we think it's going to take 8 weeks to get in and heal that thing, if we can do it in 6, we'll have a little pool set aside and we'll be able to incentivize our nurses back a little bit. Again, it's a fee per visit basis versus a per hour basis. I don't know about you, you pay somebody by the hour. Usually things take a few more hours than it would if you just paid somebody a flat rate. So you need to get it done. And again, I mentioned we have a doc in a box, or doc in your pocket, however you want to call it, because you have ready access to one of our trained physicians, one of you, who can be on the other end. So you can use this in your wound center, you can use it in the hospital, you can tie in with home care agencies to get this problem under control. Our EMR is Wound Expert through NetHealth. We turn nurses from a cost center into a profit center. So the patients profit, as do the providers. So really, if we can get in, we can actually make this less expensive by doing more frequent and earlier management of the wounds. It's actually going to save money. It may look like it may cost a couple more dollars on the front end, but it'll save, especially in those first 60-day episodes. If that patient gets re-hospitalized and the hospital has to eat it, they'll be happy to keep them out if you can get this wound healed before that ends. So we're going to be fully HIPAA compliant with this. With BC, we can also use Chiron Health or any other provider you may wish. If you have a specific one, we can brand that any way that you want. And then, of course, if a higher level of care is needed, we would refer those out to your primary care, emergency department, or 911. All right, so people say, why hasn't this been done before? Well, that's a good question. I mentioned a lot of the logistics, operational issues, but the time is now. We want the willingness to be out there to make changes. I see all these memes across different social media. Everybody says, who wants change? Everybody raises their hand, right? And then, who wants to do something about it? So everybody kind of back up. So let's do something about it. We absolutely can. Telemedicine, as you know, in July, American Medical Association started talking about having training for telemedicine in the medical classes these days. We want to bring this more mainstream. Currently, a lot of telemedicine has been primarily focused on psychology or addiction and treating. So by focusing this on... Oh, thank you. Could you not hear me back there? Am I not talking loud enough? How about now?
Much better.
I did fly in, and we got in about 3 a.m., so got my 3-hour power nap, and I'm ready to go. With lots of coffee, a little shaky, but we're good. It's a pleasure to be here. It absolutely is. So psychology and addiction, as you know, is primarily what's been done with telemedicine, but dermatology is absolutely something we can do. If you take a picture, any chart, and you look at photos, I don't know how you shake your head, but I do. And I look at some of the sizes and the measurements, and then blurry, and all the issues that come with that. So having a clean, crisp digital image that's measured, accurate, done for you, it'll make the payers a lot happier when they see accurate computer calculations that the wound was reduced in size from this size. It went down by 6.2% this week and 4.1% the next week to closure. And we'll have accurate data we can show them. So we can pass these things on to governmental agencies like the National Institutes of Health. And we can track how we can get out there and heal these wounds sooner. So payers like that because it's evidence. So pictures. Why video versus a chart picture and live? If you can see, you can treat it. The beautiful thing about using Tissue Analytics or other types of software like that is what you see is what you get. So the little green dot's great with this application because it gives you the color correction and the lighting correction. And due to the size, it doesn't matter the distance that you're taking that photo from. It uses that to calibrate it so you get a true and accurate measurement, and the body curvatures don't affect it. So we can get down to less than that 5% error rate versus that 50 to 55% error rate you can get with a tape measure. And again, no special equipment. So it uses whatever camera you have on your mobile device, Android phone, Google tablet, iPhone, iPad. We're going to bring it out for the Windows phone for other countries, such as Africa and Blackberries, if people still use those things. No, knock on Blackberry. You rarely see them. And then again, that report goes in a PDF and it's readily uploadable to your EMR and attached, or you can pass it on to other people. Some people have been asking me, is this competition? It's like, no, we're partnering with providers, facilities, agencies, and focusing on healing the patient. Okay. Want to be in with home health agencies, make this more efficient for them. They do a lot of other care for patients beyond wounds, to be able to focus on the wound care, get people in and out. Again, if you need to have 20 people out there taking care of your patient base, when you only have 5, you can ramp up quickly with crowdsourcing of staff. So supplies. Well, I don't think we want to try to supply 100,000 nurses across the United States with stuff in their trunk. So the best way to do that is use our modern fulfillment system. So there's different firms that are out there, but can anybody tell me the one company that will ship product to your house by United States Postal Service on a Sunday when you can't even get your mail?
Amazon.
See, everybody knows. So we do a telemedicine consult on Monday. We determine what we're going to do for that patient, whether it's an Electra with some RTD and maybe a Neutrophase wound cleanser, ship that out to the patient's rack or from another third-party vendor. Get it there in a day or two, at least for that first order. So when the nurse comes by in time for that appointment, it's sitting there. They may have a little welcome kit with a curette if they need to do a culture or something like that. But for the most part, they're not running around with supplies in their trunk. They can pop in, do the E&M, everything's digital. Nothing is stored on a local device. Everything's on our cloud-based server. So no photos, no charting, everything's accessed. They access Wound Expert right from their mobile. So I like using SuperNap by Switch. It's a Rob Roy company. They have the best high-speed, awesome data centers that you've ever seen. They're really cool. I can show you pictures because I've been there. It's like high security. At Fort Knox, I trained there in the 86 and 87 in the Army. SuperNap Switch, higher security than Fort Knox. I'm telling you. That's where the money really stored. So payment, Medicare has variable reimbursements for telehealth. Supplies are often billed separately. Insurances will reimburse for the telemedicine consults in most states. What we do is we accept our copay prior to the consult. So we are able to take debit cards, credit cards. Even people with cash, they go in a local Safeway and they can purchase a debit card pretty readily. We would accept private pay. There's one hospital out in Mountain View. They actually advertise that they take a 75% cash discount because they don't have to chase around and try to collect all the money. We're going to work with accountable care organizations, insurances, and of course there's always concierge service available for those physicians that are on the telemedicine side and they do the wound consults. Those waiting rooms, the virtual waiting rooms are absolutely available to do whatever other types of services that physician wants to be able to provide, if not just wound specific. We have a large list of telemedicine visit codes and E&M visit codes that are related to a range of ICD-10 codes that we're usually seeing. So why telemedicine and crowdsourcing? I mentioned in July, the AMA offered that telemedicine training be done with medical students. July 13th, they released a paper on telemedicine and ethical practice to inform patients regarding the limitations of the technology. So we will get their verbal consent over the device. We're going to encourage them to inform their primary care physician when they've been treated. Telehealth, want everybody on board, everybody sharing the information. And support those policies and initiatives to promote access to telehealth and telemedicine services for all patients that could benefit from receiving care electronically. So again, if they don't need to go down to the ED for somebody to look at their wound for 5 to 10 minutes and spend $3,500 for that visit and further clog the emergency department system, which has become our current urgent cares, we can avoid that. So we're going to need a lot of marketing to let the public know that. Again, because of the way the device is set up at the application, we can put this in the hands of the patient. Okay, they can initiate the consult. That saves time. Talked a little about Amazon, eBay, fast food, dinner reservations. Everybody here use mobile technology regularly for those things? I see something in the grocery store, I just whip out Amazon, I take a picture of it. Oh, look, there's the prices, click. But why can't I get a doctor? Why can't I get a dentist? Why can't I get other services? It's going to be 2017 real quick. So we need to embrace that and be the first out there with this. So one of my biggest things with this is access anywhere. So So the future of home care is on demand anywhere. So it's not just home care. It could be your office. If you've got a wound here and you're sitting here today, we could have a licensed nurse at this hotel within a couple of hours. That's what we want to do with on demand, on location. It could be at your campsite. It could be you went out to the beach and you stubbed your toe. We want to make this more mainstream. So can anybody do this? Yes. You, me, and all of us. So let's get started. Let's bring telemedicine mainstream. There's some of our suppliers. Who wants to see what the app looks like? Anybody interested? Let's see if this will work. I still got time?